Welcome, everybody. This is our webinar series for the Penn Artificial Intelligence and Technologies for Healthy Aging Collaboratory, or also known as Penn AI Tech. Penn AI Tech is an initiative that's funded by the National Institute on Aging, and we're launching our webinar series. We are really excited to have speakers from different institutions and with different experiences talk to us about innovation, technologies, and aging. This session is being recorded, and I'm really excited to welcome our very first speaker for the webinar series, Dr. Amanda Lazar. Dr. Lazar is an assistant professor in the College of Information Studies at the University of Maryland, College Park. She received her PhD from the University of Washington in Biomedical and Health Informatics, and her research examines the design of technology for older adults, in particular older adults with dementia, to support social interaction and engagement in activities. Her work is supported by the National Science Foundation and the National Institute on Disability, Independent Living, and Rehabilitation Research. We're very excited to have Amanda with us today. If you have questions for her, please feel free to post them in the Q&A section. And at the end, we'll have a time to answer those questions. So Amanda, thank you again.
Thank you so much for having me. All right, so the topic I'm going to talk about with you today is designing health technologies with people with mild dementia. And I'll just give this background information, though many of you who are here may know this, but dementia is a syndrome caused by conditions such as Alzheimer's disease or vascular dementia. The kind of dementia I'm going to be talking about today is mostly this kind of Alzheimer's disease and related dementias. So the ones you think about that impact cognition in a variety of different ways and are typically progressive. So dementia as a progressive condition has phases, right? So starting, we could even talk about preclinical dementia. There's mild cognitive impairment, which actually is not a form of dementia, but sometimes does convert into dementia at a later point. We have mild dementia, moderate dementia, advanced dementia. And what I really want to hone in on today is this phase of mild dementia. So in mild dementia, what does this look like? Well, people are beginning to face challenges with complex tasks, but they're able to maintain many activities, and especially with adequate support. And we'll talk about what that support looks like in a little bit. People can live with mild dementia for a short period of time or for many years. So even though there is this kind of spectrum of dementia, we often do go to these end stages of dementia in our minds when we think about this condition. We might think about 24-hour care, complete inability to recognize, at least in the way we think of what recognition looks like, familiar surroundings and people, and really significant changes in communication abilities. So maybe it's not so surprising that our technologies for dementia are primarily designed for the following purposes. We have technologies designed to support caregivers, many for informal caregivers who might be family members taking care of a loved one with dementia. Usually when it is designed for someone with dementia, we see it designed for really passive engagement or assumptions of stagnant abilities of people with dementia, these more kind of advanced stages where people can't communicate in the way that we're used to. So what does this look like in the world of artificial intelligence? We are seeing a lot of research and kind of news articles, excitement around this idea of detection. And there's big reasons for that, right? A push towards early detection, and also something that AI seems to be able to do from different kinds of sources. Here's one from retinal photographs. There's work on keyboards, the way people type, right? And early detection as well, right? So even the goal is to get towards that preclinical stage potentially. We're also seeing AI used in lots and lots of research for sensors to detect changes or falls, or just kind of general monitoring of people with dementia in their homes. So these are examples where the person with dementia themselves is not necessarily needing to be an active player in the use of this technology. What I'm going to talk about today is what we can do to design with people with mild dementia for more kind of active involvement from them. And I argue that there are 5 things that are really important to consider here. We're going to start off with this first one, which is usability. So when we think about usability, right, something that is usable, someone can come up and use this technology. Someone with mild dementia can come up and use this technology. A lot of design we see is really focused on these cognitive changes, these memory changes in particular. So here you see an example of what's literally called a simple music player from a store online, where you can see that it's been simplified as much as possible so that someone with dementia just has to kind of follow these instructions. There's only 2 options, right? So we're seeing a design to accommodate cognitive change. Often the goal we see here is to facilitate sensory interaction, things like music therapy, right? We know how beneficial music can be. But there are the activist space in dementia and also clinical literature is telling us that people living with dementia do not just experience kind of memory changes, but there are these complex sensory changes as well that happen with the condition. So for example, people have spoken about how when an elevator door opens, depending on kind of the flooring in that elevator, it can look just like a pit, an endless pit at the bottom. So it's scary to get into, isn't it? So in my world of technology design, we wanted to understand how do sensory changes affect technology use of people with dementia, right? So we have an understanding of kind of memory changes affecting use, but what about sensory changes? So to answer this question, we conducted 30 semi-structured interviews with 11 people with mild to moderate dementia, as well as 19 practitioners. But before I get into any more methods, we need to talk a little bit about the people with dementia that we spoke to. So here I have another kind of assumption for us to look at. So when we think of a person with dementia, we may think of someone with older age, but there are roughly 10% of people with dementia who are diagnosed before the age of 65, which we call early onset dementia. Some researchers have written about kind of like a profile of these individuals, right? So there's this more, Charles Worth citation calls it the rise of the young active person with dementia. So people who are perhaps more comfortable talking about their condition despite the tremendous stigma, people who might be more in the kind of activist circle, pushing for change and attitudes. And given the demographics of technology use, this group may also be more tech savvy, especially because of their activism as well, which can take place online. At the same time, we do know that older people are increasingly using technology, and some research says that around 50% of people with mild cognitive impairment and mild dementia are using technologies like smartphones. So I say all this to say that this is not a representative sample of the people with dementia that we've spoken to. Yet there is a lot that we can learn from them, and they do represent a kind of portion of the population. All right, so to supplement this kind of very specific sample, we also spoke to 19 practitioners who work with people with dementia in a variety of ways. So speech language pathologists, activity directors, different kinds of roles. So back to our question, how do sensory changes affect the technology use of people with dementia? But also, and you'll see this across the different works I'm going to talk about today, how do people with dementia adapt their use of technology to respond to sensory changes? Because it is really important, we found, to look not just at the kind of barriers that our technologies pose, but also the idea that people have developed these workarounds. They've made things work for them. Okay, so what did participants tell us? Well, they described how, so we know from the literature, right, that dementia affects engagement in everyday activities, and people confirm this. They talked about a wide range of activities that are affected, things that involve decision-making, keeping track of things, navigation, engaging in social gatherings, grocery preparation. And our current research talks about those usually in terms of kind of cognitive barriers, the decision-making, executive function, right? Those kinds of things. But people described how much sensory aspects of their world affected their ability to engage in activity. So one person said that the physical world, just like, you know, the music that you hear playing and the conversations and the dishes clinking and the people moving and the trucks driving by, that's all stimuli. And we actually saw this in practice because in one of our interviews, someone actually paused during the interview because there was a loud truck going by. I think it was a garbage truck picking up trash, and they weren't able to kind of retain that focus on the conversation and engage in that way. So perhaps not surprisingly, technology can be a source of overstimulation. This is both at kind of a large scale, if you think of going to New York and Times Square, right? But also even the technologies that exist around us. So loud TVs or web pages that are noisy and flashing. So one person described how just trying to look up and follow a recipe for dinner, they experience visual overstimulation, where it's a challenge to just get to where I need to go, to find the information that I need and not to go through all the weeds, you know, in between. So these kinds of visual distractions can be get in the way for anyone, right? But in dementia, it could pose such a significant barrier that it could completely stall out the activity. But technology was not just a source of overstimulation, but people also used it to overcome sensory stimulation in the physical environment. Several people described using noise-canceling headphones to either play music or use the noise-canceling mode to block out all kind of auditory stimulation. People spoke about going out into the world in traffic and crowds and being able to use that noise-canceling headphones to be able to exist in that space. So here we're seeing people using or not using specific technologies in order to achieve their desired levels of stimulation. But that wasn't always possible. So at times people adjusted the settings of the technologies using settings already set into the operating systems. So, and here's a good example of that kind of fluctuating abilities, right? One person with vascular dementia said that his condition gives him kind of varying effects on his dexterity. So when he's not having a good day, he often experiences problems with his fine motor abilities. So in those instances, he'll use voice to text to dictate a message to himself because the keyboard is much too small at that moment in time. For fluctuating visual abilities, practitioner and occupational therapist spoke about adjusting lighting. Other people, which is, you know, one of the built-in settings in our systems. Another person spoke about adjusting font sizes, and that let them keep reading when they would have had to stop hours ago otherwise. Another strategy we saw was switching devices entirely. And this was to when they weren't able to adjust the settings to get what they needed, so they need to choose a different device to get the kind of input or output that was more accessible. So as one example, people switched from typing in these kind of journal diary entries, which helped with kind of remembering the events over time, from typing to recording using a voice assistant. Another person mentioned that their smartphone buttons were just too small and it was too hard to press, a combination of dexterity and vision. So they switched from smartphone to a tablet. But overstimulation cannot always be avoided. Technologies don't always have adjustable settings in the way that people with dementia need, and alternative technologies cannot always be found. So at some points, people did completely cease use. Sometimes replacing technology solutions with non-digital solutions. So one person said that on days where her memory was really bad, unlocking her phone, opening a calendar, getting directions to her next appointment was just too much. So she actually kept a Post-it note, which she referred to as a tactile reminder, in her hand, and that could persistently remind her of what she needed to do next. At other times, there wasn't really a substitute that people could use, like in the case of online forums for people with dementia or websites or social media, in which case they kind of lost the ability to engage in those venues. So what are implications of this work? So first of all, these fluctuations represent a really interesting AI design opportunity. And by fluctuations, I mean how people spoke about changing visual abilities over the course of the day, or even from day to day or hour to hour. We think about kind of passively detecting cognition over longer terms and changes in cognition, but this work would argue that we actually have the opportunity to benefit people with dementia directly by detecting these fluctuations and figuring out what to do with it. Now, that's not an easy research question either, right? Do we change the interface, or does that become more confusing? Do we have a kind of virtual or human support pop up to help them in those moments? There's a lot of kind of exciting opportunities here. Another kind of interesting implication of this work is this concept of assistive media, which was put forth in prior work as this idea for advanced dementia, where we know how much music therapy can benefit people. But here at this early stage, media was not just a way of enjoying sensory experiences, but it was actually something that people used to help them focus. So one person spoke about during meetings, he would put his headphone in and out of his ear to help him focus on what was happening in the meeting. Again, seeing that fluctuation. And finally, sometimes we think of dementia as such a distinct category, not even considering it a disability, but we see people using these built-in settings that were designed and pushed for people with disabilities. People are using these to adjust the text size, to adjust the lighting, to adjust contrast. And there's a lot we can learn from looking at advances made in other communities. So hopefully by now I've convinced you that usability does not just involve kind of memory, cognitive functions that we typically think of with dementia, but also that sensory abilities are intertwined with the kind of more cognitive memory type abilities, and it takes they mutually influence each other, and we need to think about both when we design. The next one I'm going to talk about is the role of others. Now, role of others is a really interesting topic in dementia, and there's a lot of work on this in advanced dementia from many different researchers who've done some really interesting thinking about how other people are involved in kind of holding up what it means to, or that others really influence the course of someone's dementia, the way others kind of treat you and position you and things like that. But there are these kinds of mild nuances in mild dementia that I'm going to talk about. And I'm going to do this through talking about a study that we did on self-management. Now, self-management is a term that is refers to the day-to-day management of chronic conditions by individuals over the course of an illness. And it's been studied for many different populations. One that comes to mind easily is diabetes, right? So you get a diagnosis of diabetes and you need to learn the ability to manage the symptoms, the treatments, the lifestyle changes that are necessary to live with this condition. But there's much less work on self-management for people with progressive conditions, and particularly for people with progressive cognitive conditions. And this might be one reason why self-management technologies largely neglect these really mundane tasks that actually constitute a great portion of what daily self-management of a chronic condition looks like. So not just measuring blood glucose or taking other kinds of measurements, but getting out of bed at the right time, right? Going to eat breakfast, making sure you're getting those 3 meals a day. So the kinds of things that are actually perhaps the most important in a condition like dementia, where it's not like there are treatments or measures that you can really meaningfully do that are going to be the most influential for your life. So for this work, this actually involved a secondary analysis with some more individuals that we recruited with mild to moderate dementia from the prior study. What we learned, and again, so reminder, right, these are these tech-savvy, mostly early onset individuals. And technology was an integral part of their self-management systems. So people they use these evocative terms to describe these technologies: a crutch, safety net, my brain, my best friend. Like here again, we see a parallel to the disability community, mentioning that it was like a wheelchair ramp. People really held these technologies close. People said, I forget lots of things, but I never forget to have my phone. Some people switched to smartwatches because that way it was always on them. They can make sure it's always there because they relied on it so much. I'll give one example of a really interesting kind of blend of different technologies, including voice assistants, so kind of like an AI-based technology as well. So Arthur has designed his daily routine, which starts the night before. And the night before, he's programmed his voice assistant to remind him to refill his teapot. The teapot is connected to a smart plug, and it heats up each morning at a pre-specified time. Once it heats up, his Alexa wakes him up by saying, Arthur, your tea is ready. With his tea in hand, he then receives his flash briefing from his voice assistant with his preferred news source. After his news briefing, he does a mindful exercise with his voice assistant. And he says the purpose of this is to get rid of the cobwebs, right, from waking up. So Arthur has a background in programming, and he has used this to include reminders in non-standard language. So he's found the most effective thing for him is for his voice assistant to tell him, Arthur, you need to have a shower or you will smell. When Arthur is ready to leave his house, he takes his tablet enabled with the voice assistant system he uses, Alexa. And so he has this kind of single portable system that he can use throughout his day. He says that the system that he's designed keeps him in that routine that he's established to work within the context of his daily life and social relationships. So not everyone went as far as Arthur, like to personalize the output from their voice-enabled devices, but this kind of constant and personalized use of devices is typical to how participants in our study approached their kind of design of these self-management systems. So Arthur's example does not include another person, you may notice, and that's specifically because he designed the system in part to avoid burdening his wife. But others definitely intertwine support from people and technology. So the most striking example is Linda, whose kind of system consists of 20 caregivers, and caregivers here we can think of loosely, right? So the doctor she visits for this condition, the nurse for another condition, but also people who she selected to help with home organization, calendar management, financial assistance, physical training. So these all these different people, as well as different technologies that all work together to, as she says, keep her independent, upright, mobile, connected, and safe. So we could talk all day about the systems that people design because they're very interesting. But what's also interesting and important to do is look at the kind of considerations that they employed when they designed these systems, because I think here is where we can really learn ideas that may be useful for in our design with others. So across all of the practices and strategies people described, there were three central considerations in their design of self-management systems. There was this future-focused approach where people recognized the changes that they were going to experience in their cognition and prepared for it in different ways to different extents. And then the two relating to the role of others are this idea that people had this socially situated awareness of other people's perceptions and needs that affected the ways that they put together these technologies and people's support. Also, they had very strong preferences for ensuring that they could maintain control over these systems while also understanding the realities of their condition. So let's start with this self-management in a social world. So people, one thing that came up strongly here was that people were aware of the stigma of dementia and were eager to use technologies to project normalcy and fit in. For example, someone who had a spreadsheet that they used to fill out when they spoke to someone so that the next time they spoke to that person, they could easily recall things like their wife's name, where they live, so they could kind of engage in the way that they did before. Someone wanted a device that could provide social background information, like how I need to be presented so I feel that I could participate like everyone else. Another person spoke about how when they were in public, if they got lost for a second, they would hold their phone, not only to look for directions, but also so that they could hold their phone like anyone else might and not look like a lost person, a victim, someone who needs help. In addition, people were thought about and kind of tried to manage the impressions, not only of these people in kind of public or friends, but also those closest to them. So they actively considered the preferences and needs of their loved ones, their children, their spouses, as they designed their self-management systems. So one person, we saw that beginning example with Arthur, right, who designed this entire system that did not involve his wife. He wanted to avoid burdening her. Another person wanted to use geofencing, but didn't use it because her daughter wasn't really ready for that. That felt too soon and too scary for her daughter, so she didn't implement it. Another didn't use a smart doorbell because her husband feared that someone could come in. So that's self-management in the social world. We also felt maintaining control is a theme that also involves a lot of consideration about the role of others. So one person mentioned that it can be so tempting, especially for people with dementia, to let go of decision-making, to let go of choices and problem solving and resolving confusion and chaos because it's so tiring. And yet they were extremely motivated to maintain control over the system. And that's because the consequences of not doing so were so dire. So in some cases, these consequences look like what we assume, right? So this kind of nefarious interference, technologies that could be hacked. Also, online banking and shopping starting to avoid that because they were worried that their abilities to determine risks were compromised. Some people discussed in particular fears about AI, both in terms of it kind of being hacked somehow, but even a mistrust of the developers or writers of the algorithm itself that was involved in artificial intelligence. But people weren't just concerned about protecting themselves from nefarious others, but also those who were well-intentioned. People described how there's an awful lot of people that think they know what's going on with people with dementia and they don't, and that's a huge problem. This included other people, right? But also technology. Some people said they wouldn't want a technology to assume the state that they were in because it couldn't really know them the way they could, right? So thinking about kind of sensing, detection capabilities, being a little wary of that. And when I spoke about the kind of consequences being so steep, here was one where a lot of people brought up how if things go wrong in this case, they could be sent out of their homes, right? They could lose the ability to live independently, and they could be moved to a nursing home or assisted living. So the stakes are quite high for letting other people into your system. So what are our takeaways here? Well, we can see there's this assumption of stigma resulting from revealing cognitive status, right? The people holding their phones. So that's something that we can remember, that when we design technologies with people with dementia, especially mild dementia, something that shouts dementia may be avoided because it is affecting someone's kind of social standing and their ability to manage others' impressions of them. A second implication is that we often think of caregiver burden, which is very important, and we less think about that people with dementia, especially in these early stages, can be aware of the challenges that their family members or loved ones are experiencing and are mindful of these and would like to avoid it as well, right? So we could really include include the whole kind of dyad or social network in these systems, in the design of them, but also in the way they work. And then finally, this fear of losing control. We have to realize that this can be really central for people in these earlier stages who can see what might happen if they let people or technologies in. So recognizing that in what we would design or avoid, but also what our technologies can do, and keeping conscious of that. So the last element of this framework that I'm going to discuss is emotion. So I argue that when designing for people with mild dementia, we need to consider emotion. This is actually true for everyone, but I think the specifics of the condition and the way we talk about it make it particularly important to do so here. So this study was designed a little differently. This was actually a participatory action research study. And here we involved 2 dementia experts, so 2 people living with dementia, who we've been collaborating with for a couple of years now on different kinds of projects. And though this was our first time doing this participatory action research approach, as well as 3 academic researchers. So what we did here is we as in the dementia experts and the academic researchers, recruited and conducted contextual inquiry sessions with 16 people with mild to moderate dementia. Again, these individuals were mostly early onset, but here they weren't that same kind of activism profile. It was actually people that some of the experts on our team knew through support groups or through other venues. So including people with dementia on our team helped us recruit people with a kind of going towards that more represented profile than we were able to alone. It also had a host of other benefits, including, so the dementia experts also participated in interviews. So they interviewed the people they recruited. So, and engaged in analysis with us and the writing and presenting the work as well. So we conducted this study to understand what barriers exist for people living with dementia who are encountering online health information. Also, what mitigation strategies do people with dementia employ when they encounter these barriers? So again, the theme throughout these 3 studies I'm talking about, right, is not just what are the ways that our technologies make it hard for people with dementia to use them, but also how are people adapting and how are people using them anyways, and what can we learn from that? Both in terms of what to avoid, but also what to design for. So we found 4 barriers that people experience in accessing online information about dementia. This included a lack of relevant information. So lots and lots and lots of information targeted at caregivers, and less for people with dementia themselves. So people spoke about having to kind of interpret it for themselves. So reading an article that talked about, 8 tips for caregivers of people with dementia, what to do if someone's getting frustrated, and tracing back to understand why they were getting frustrated, trying to trace it back in that way. But also a lot of people had kind of non-standard forms of dementia, or had been diagnosed with multiple different conditions before getting to dementia, and were having a hard time finding information that was relevant to them or to their stage, that earlier stage of dementia. There was also a barrier that involved inaccurate and oversimplified information. So kind of striking and interesting example was someone said, so with a kind of public health perspective on what causes dementia, right? We think about environmental factors and lifestyle things that happen from a young age, right? It's not just that when you're 60, you have to start playing crossword puzzles, but rather all of these aspects of the world in which you live and the resources you have access to are affecting whether you might get dementia down the line. But someone read about I think it was wearing seatbelts to avoid crashes, to avoid traumatic brain injury, and said, well, I wore a seatbelt my whole life, right? And I got dementia, so what does this mean? People spoke about information that elicits distrust. So this was what you might expect, like kind of scammers or worries about sharing information, but the distrust extended to anything where they thought there might be data mining going on, even if it was something like signing up for a clinical trial, yeah, and there we see kind of a parallel back with that previously we spoke about with the kind of artificial intelligence and fears of control coming from there, right? So this awareness of the risks of technologies that we often assume does not exist. And the last one that is relevant to this kind of emotional dimension is this idea that information about dementia that they wanted to access to use as part of their kind of self-management was inaccessible. Now, the inaccessibility was due to different factors. It was definitely due to cognitive concerns. It was due to sensory things like we just spoke about earlier, but also there was a large aspect of which it was emotionally inaccessible. So what do I mean by emotionally inaccessible? People spoke about how if you just type it, so just type into Google the word dementia, you're going to come up with loads and loads and loads of negatives. They described existing resources as very depressing. There's nobody giving you any hope. So what did this hopeless information look like? Well, it was about life expectancy, right? It was about end of life preparation, this idea that you need to go straight to, like many of us do in our minds, right? Going straight to that advanced stage and thinking about death instead of all the time that people have to continue engaging in meaningful activity. A lot about this lack of cure, right? And that's something that we can use to help us perhaps motivate fundraising and interest in this space. We don't have a cure yet, but it's also read by people who have the condition and see that kind of hopeless information. So what did people do in response? One strategy was to reduce their exposure. So they deleted newsletters entirely before they even read them. They avoided information from different organizations that they found to trend more negatively. They also engaged in selective avoidance. In other words, they chose kinds of information that were particularly harmful to them and avoided that. So for example, people talked about avoiding information about stages of dementia as that being something that was really challenging for them to read about, these later stages. They wanted to kind of be present in the moment in what they were in and avoid that other stuff. People also paced themselves. So they discussed kind of saying, okay, I'm going to read through this much information for the day. I'm done. That I've filled my quota for the day of this kind of information that felt kind of emotionally inaccessible. So what do we get from this? Well, we know that content about dementia is negative. There have been many researchers who write about using approaches like discourse analysis, right? The ways that dementia information is very negative. For example, there's one really interesting study that talks about how dementia is almost talked about as a condition, like a non-human condition, like a zombie, where it's like people are losing their self. So it is intense the way that dementia content is spoken about. But we may not always be thinking about that people with dementia are accessing this content, right? We know that older people are reading this, and perhaps that's why some fear dementia worse than any other condition, including cancer, right? But maybe we're not thinking that people with dementia themselves are accessing this content while they're trying to find information that they can use for themselves. So with this in mind, there's implications for many different kinds of practitioners to think about phrasing and materials that they make available widely. But also there are many artificial intelligence opportunities here, right? We have sentiment analysis tools that maybe can be used to detect when content is particularly negative. We have, we're able to do topic modeling, right? For that kind of selective avoidance. Are we able to identify topics in advance and help people find the ones that they're interested in and avoid the ones that they aren't. So across these different topics, right, in kind of focusing on the experiences of people with dementia, I hope that we have been able to see that there are a lot of possibilities for technology design in this space, including artificial intelligence technologies, which to date have been used for really important purposes, but often focused on the caregivers or that kind of passive sensing. But there are so many opportunities for us to use AI and other emerging technologies to design with people with dementia. And I think we can really keep this framework in mind of these usability and sensory dimensions, think about the role of others, that emotional aspect. And then one that I didn't get to talk about today, but embodiment is also really important in dementia as well, right? The way that motor memory is retained long into the condition, the way that we move our bodies can be really important. And our emerging systems are able to kind of take that in ways that they couldn't before. So where is this work going? One thing I'm continuing to focus on is this idea of attitudinal change, because I think reading up on the work of activists and also researchers who talk about how the way we think about dementia goes in a certain direction. Once we kind of change the way we think about dementia, there's all these new technology design opportunities that open up, opportunities for really interesting innovation, right? Really cool new spaces for us to go that I think have not been done before. So to do that though, right, we need to find better methods for working with people with dementia. And for the work I'm talking about today, specifically working with people with that kind of mild stages. So this could involve training the next generation, right, in methods that they can use to involve people with dementia in the design of technologies. So this user-centered design idea, right, where we interview people about their preferences and needs before we go off and design technology or the intervention or the information resource. But we need people who know how to do that. We also need to think about from the other side, right, how the experience is like of a person with dementia who's recruited to work in with us. Now, I kept talking about this kind of activist profile of people that we've engaged, and that's because, in part, I believe, the term dementia is so stigmatizing that if you want to go out to the community and get people who have mild dementia, so not having caregivers sign up people in advanced stages, people with mild dementia, it can be very painful to talk about. And a lot of people in those earlier stages are not diagnosed, right? Especially depending on different populations we're talking about, where diagnoses are more or less stigmatized, or people have more or less access to the kinds of clinicians who are willing to diagnose or able to diagnose. So there's a lot we need to think about in terms of how do we define the terms we use so that we can engage the people we want to be able to talk to. And finally, in terms of our methods, extending the possibilities for involvement, right? So how do we make sure that we're not only talking to, I mean, the classic research problem, right? We're not only talking to retired professors, for example. And this is an area where I'm really have become interested in remote design and opportunities there. This introduces even more challenges around kind of ruling out parts of the population, right? Because then you need someone tech savvy, perhaps, access to technology and a good connection. But I think there's a lot of innovation that we can do in this space to make it more accessible for others. So with that, I want to thank you all for listening, and I want to make sure to show my collaborators. So Emma Dixon, who has now graduated and is at Clemson University, she led a lot of the work that I'm speaking about. And then we also have our collaborators over here. So Mary and Diana were big parts of our ability to do the research as members of our research team. So with that, thanks everyone, and I'm looking forward to questions with you.
Thank you, Dr. Lazar, for this great talk and really inspiring. We have several questions, and I wanted to first ask about the issue of informed consent as you engage people in your own research, but not just within research. When we engage older adults with mild dementia in research activities, what recommendations do you have about making the informed consent process a meaningful one, given that obviously people have varying degrees of experience and familiarity with technology?
Yeah, that's a really good question. So I think there's a bunch of kind of dimensions here, right? So there's first the question of, can people consent with dementia, right? And there are a lot of kind of nuances there. And I should have made a backup slide on this because this is kind of a path I've gone to over time. But there are protocols. We use the UC Davis protocol to assess capacity to consent for a study. So these include questions like, as you're going through the consent form, you ask things like, can you tell me about what the goal of this research is, right? So you're making sure that they're understanding those key aspects of the consent form. And this is usually when we're going to people who are more able to kind of reach out to us, interact with us. In other settings I've done, I have involved legally authorized representatives who've had to provide consent in other work I've done with people with more advanced dementia. But then there's also arguments, I think, starting in the UK, that we should be assuming capacity to consent and only when questions are raised should we assume capacity to not consent. Of course, I'm doing interview studies, right? So for the clinicians in the space and people running pharmaceutical trials, right? Risks look different, things look different. But what does assuming capacity to consent look like? Well, if someone sees a flyer on a wall and they call me up, they schedule a visit and they come to that visit, do I need to, find out if they have a legally authorized representative that can provide consent for them? So those are some of the dimensions there. And then in terms of I think maybe you're referring to kind of an ongoing consent or ensuring people understand kind of the technologies and what they look like before kind of signing on to get them. That's been a really interesting problem, I think, that people have, because often they are not, it's not with this group I'm talking about now, this tech savvy group, right? But a lot of people don't quite understand technology's capacities and capabilities until they use them, and not just older people, right? Anyone. So that's a whole interesting question that we've been working on with a different student who just graduated, Alicia Pradhan, who's been thinking about how to really help people understand what these capabilities of technologies are, or tap into their existing knowledge in our design work.
Great, thank you. We have a question about how do you go about preparing your students engaged in co-design studies to be reflective about their own ageism and assumptions about dementia?
Yeah, this is a big one. So I'd say it kind of starts when they start working with me. And we so often come to the table with innocent terms, right? Or innocent ways of thinking about it, like patients, saying someone's a patient with dementia, but we're not talking about a clinical system. They're actually a person in the setting we're talking about them. So there's a lot of modeling, right? The words that I use, even in response to the words that they use. There's sometimes when it gets closer to actually working with someone, that's when I start talking about, oh, these are the terms we want to avoid. These are the terms that we want to use. Readings, there's a lot of incredible readings about ageism or kind of anti-dementia perspectives and how to reflect on those. I think it's cultivating kind of a lab culture of understanding those and educating each other on those. But also the people we've worked with dementia are educating these students as well, right? They're also saying, hey, that we don't like that word, right? And I think this is really important because it can be really easy to tense up and worry so much about saying the wrong thing that you kind of stall out, right? Not to say that our typical participants should be needing to educate us, but I think that's why we need to work with people with dementia in these kind of more kind of directing roles of our work so that they can help educate us on these nuances.
Thank you. The next question is from a participant who says they're curious about memory training for people with mild and moderate dementia. Some people at the early stage indeed want to improve their memory, but currently people don't know any evidence-based training tools based on technology. Do you think that might be a direction for the AI development?
That's an interesting question. So I think that there's exciting opportunities to look at education as something that happens across the lifespan, right? Because it could be really protective as you're younger or middle age, right? As things go on, that's, I think, when we can have the most impact with our memory, our kind of cognitive building, right? Our learning to play musical instruments, our access to quality education that is affordable. To me, those are the most exciting opportunities, which is funny, right? To help people with dementia, we're actually, working with kids who will become older. At the same time, I certainly can understand people who have a diagnosis or fear diagnosis are really, really motivated to kind of stay active and stay sharp. And in part because of that tremendous fear of what it might mean if they receive a diagnosis. So I do think there are definitely opportunities to kind of turn to the evidence-based, what we know, thinking about skills that are transferable, right? It seems like the kind of embodied, there's that embodiment piece I didn't get to, those kind of embodied movements and learning can be extremely useful, like dancing, right? There's a fun kind of VR, maybe AI opportunity there. So I think, yeah, returning to that evidence base and going from there for sure is the way to go.
Question we got about when you mentioned that about 50% are using smartphones, is there any information or breakdown or any estimates about what features or functions within a smartphone they might be using?
I need to go back and find that reference. So maybe we can send it out to attendees. I don't know if you send out the slides or something.
Absolutely, sounds good. Do you have specific reasons that you target persons with mild dementia in the context of their ability to use technology?
Yes. So I've worked with people with advanced dementia before, and there's so much to do there too, right? So I could give a different talk on all the amazing opportunities we have to work with people with advanced dementia. But over time I have, or more recently, I have been moving to this space because there are so many people, this kind of intersection of, or the way that stigma or negative feelings towards dementia have just clouded everything about living with mild dementia means that there's so much we can do there, right? Because we're pushing towards earlier detection for a lot of different reasons, including seeing if we can figure out this kind of medication approach, right? Which means that more people are going to know they have dementia and be very aware of it while they're living their normal lives, right? While they have a job, while they have maybe older children, especially if we can get towards that preclinical dementia. Imagine that, right? So just with that trend happening, I think we really need to start thinking more actively about not just from the outside, oh, these people with dementia are moving around in the world. We have to make sure we know they have it and then track them and detect it. But we need to realize that when you get a diagnosis, you have so much that you can still do and focus on those pieces as well. So I'd say that's why I've kind of been moving in this direction over the past couple of years.
Great. Another question is, there are a lot of interesting themes you have discovered, like the idea of assistive media, emotion, embodiment. Each of them requires substantial time and resource, including students to go deep. How do you plan to further expand on these sub-research areas?
Yeah, that's interesting. I guess I would say that I've gone to each of these by going deep on a different topic, like the self-management study, right? There we were just trying to think about how people are using everyday technologies to stay engaging in everyday activities. And that's where this kind of role of others piece came up. So these are almost more kind of reflective threads that I'm seeing across the work that I think are going to appear in anything we do. So I think it's kind of an across the work factor. But then there are opportunities, of course, to go really deep on additional projects as well on any of them.
And during your interviews with people with mild dementia, did you find any trends regarding the rejection of novel technologies regardless of interface? Or was adoption or rejection of a given technology more associated with the communication media with the novel devices such as text, speech, images?
Okay, that's a really interesting question. So I'd say there were mixed responses to this, right? So for some people, like many of us, right, there are these shiny new technologies that we think are going to be amazing, and we all get excited about them. So some people were certainly like that. You know, the newest cutting edge technology came out, they wanted to get it. But there is an aspect here of dementia where, like some of the other elements we're talking about, right? It's not that these exist only in people with dementia, but with people with dementia, it can cause such barriers that it can completely halt use. And one of these was adjusting to new technologies. Now, people with dementia, I mean, this is controversial, but people with dementia can learn, right? Can adapt. But something that we found in particular that was really challenging was updates, right? So when we get an update to our technology, we get these new features, all of a sudden everything looks different. Thinking back to those dimensions, right? The embodiment piece that I didn't speak about, you're used to moving in certain ways to navigate across your screen, and now you require entirely new ways to access. So I'd say that there's kind of a mix. The population we spoke to was definitely open to new technologies, but there were elements of adjusting to new technologies, like that adaptation that was required, sometimes that fear of what's happening with my data in the newer technologies we have that existed as well.
There are so many questions that we didn't get to yet, and many great questions. So I think I would encourage all of you to contact Dr. Lazar individually to start that dialogue. Somebody asked if we're going to share the slides of the lecture. Yes, both the recording and the slides of the presentation will be shared with everybody who has registered for the webinar. Dr. Lazar, thank you again so much for this great presentation and for being our inaugural speaker for our webinar series.
Thank you for having me.
I also want to thank everybody who attended and remind folks that our next webinar will be on November 3rd at noon Eastern time. So looking forward to seeing you all then. And again, thank you so much.